I think the first and foremost thing to really start embracing the practice of fluid stewardship is acknowledging that fluids are medications and scrutinizing them in the same way that we do any other medication therapy. When we talk about fluid stewardship, I like to think of there's two different frameworks that really help me structure my approach to patient care. The first is the ROSE model, ROSE, and that is rescue, optimize, stabilize, and evacuate. And when a patient is in the hospital, at some point, they may not go through all four of those phases, but at any given time point, when a pharmacist is evaluating that patient, I think it's important to identify which phase of the ROSE model is this patient currently in. And if you can first identify the phase of the ROSE model, then that can help you conceptualize what are the goals of this patient's care and therapy as it relates to IV fluid administration or removal. And once you identify what phase of the ROSE model the patient is in, then you can use the 4 rights construct of fluid stewardship. And this is very similarly framed as the 5 rights of medication safety. And so the 4 rights of fluid stewardship are: is it the right patient? Is it the right drug? Is it the right route? And is it the right dose? And so is it the right patient? Do they need fluids or not? And or maybe even diuretics, is it the right drug? So if you decide to give the patient fluid, what is the right IV fluid to give? The right route. I think sometimes it's easy to assume that a patient needs IV fluid therapy because they are in the hospital. But could the patient take enteral food and enteral fluids, or even volitional? On their own accord, sips of water, ice chips, that type of thing. And then the right dose. So if you're going to give a patient fluids, IV or enteral, et cetera, how much fluid do you want to give them cumulatively, and at what rate do you want to run it at? I think maintenance IV fluids are very overutilized in the hospital setting, and it's really easy to put them on maintenance fluids and then kind of say, oh, I have addressed their IV fluid needs, and then you don't revisit that therapy. And so similar with antibiotics, antibiotic stewardship practice, you are quick to choose an antibiotic that is an appropriate spectrum of activity based on the suspected pathogens. You de-escalate at earliest possible. And you also add stop dates, so you don't give any antibiotic in addition, any days of antibiotic more than what you would specifically need. And so similarly with fluids, if you want to give fluids for some specific reason, consider putting in a 24-hour or a 48-hour stop date. Or if you look at maybe what their body weight is and you have an idea of what their fluid deficit is, then you can be very deliberate with the rate and the duration of fluids. So you give only the set amount, and then you can go back and revisit that. Maintenance IV fluids, I think, if a pharmacist wants to get involved, just look at your census, the patients that you are responsible for in the hospital setting. Do a quick scan and see how many patients are receiving maintenance IV fluids. And I think the literature would suggest that roughly 2/3 of your hospitalized patients are receiving them. And those maintenance fluids make up over 1/3 of what their cumulative fluid volume each day encompasses. And so a very easy initial practice for someone right out of the gate getting started: find out which patients are on IV fluid therapy, maintenance fluids particularly, and just evaluate the need. What is the indication? And how are we assessing safety and efficacy for whatever that indication is for these fluids?